have one suggestion. Can you get me connected with that person of FTP so that even simultaneously I can also follow up with her so that we can have a good number of attendees.
Yes, I think we can, Priya.
We'll figure that out, man.
Yeah.
Right now,
Right.
we'll figure it out and see how it is to be done, because Vimal has to follow certain Government of India guidelines for the process. Because we have announced publicly now that we'll be marking the faculty members.
Right. Priya, we'll talk about it. At
Later.
very convenient times. Yeah.
Yeah,
Fine.
we'll do this later.
But Mukul, even if there are only a few of us on Zoom, you can be sure that YouTube has got plenty more.
Yes. I think we are live on YouTube. I think.
Yes.
We are live on YouTube.
Yeah.
And these sessions are being recorded and they go for the faculty development program also.
Okay.
So we have a very robust where we are educating the university professors on cancer control measures. And
Wow.
all this is recorded and put into their e-learning
Okay.
material. And then we quiz them on it.
Oh,
It's not
fantastic.
so easy. They have to learn, they have to understand, and then they have to give a test.
Yeah.
And then it goes in their performance appraisals.
Okay. Wow. That's a very robust feedback system then.
Yeah.
Dr.
So
Roy,
our doctors reach out to a larger audience,
Right.
even though this would be a small audience.
Right. Nice.
actually, Dr. Roy, of course, Priya is operation head, but she's much like a sergeant. She knows everything, how to deal with the situation and everything. So I truly enjoy working with the Priya and Jyotaji as well. So anyway, Jyotaji, shall we start now?
Yes, I think so. Are we live on YouTube?
Yes, we are. I can see it.
Good.
Alright. So good evening, friends. This is Shrenik. I am having a commendable privilege and honor of being a patient ambassador and coordinator of Indian Cancer Society Delhi. Today is our 23rd session back to back on every Friday, and I am super excited to introduce Dr. Mukul Roy. She is from one of the India's most premier medical treatment center, that is just Love Hospital, and she is commendable radiation therapist. So, Dr. Roy, thank you so very much for spending your valued time with us, and thank you for making it today. Kindly proceed with your expertise, knowledge sharing, and everything. Platform is all yours.
So thank you, Shrenik ji, for such a nice introduction, and thank you for giving me the honor and the privilege to actually come on the platform of Fridays with Shrenik. And thank you, Jyotsna ji. Thank you, Priya ji. Thank you, all of you. Um, I'm really humbled, I would say. I'm very humbled that you considered me for this session, because other than the passion that I have of treating cancer patients, spreading cancer awareness is very close to my heart. So yeah. So to begin with, I would like to, I'm not going to present any boring presentation with scientific data and everything. I'm going to make it very simple and short and make it more interactive. Shrenik ji, I wanted to ask you, can anybody who's watching it live on YouTube ask questions?
Yes, absolutely. And Ritika, our coordinator, whatever questions comes in, she will be able to let us know and you can answer suitably.
Okay. That's all. So basically, India is a developing country, and the cancer burden in our country is very high. So as per the Globocan data, it is one of the countries where cancer is soon going to become an epidemic. So, and amongst cancers, head and neck cancer, we'll be focusing more on head and neck cancer today. So, head and neck cancer is one of the most common cancers in India. So, as a cancer doctor, whenever we are doing our training, head and neck cancer is supposed to be the bread and butter of the main sites of cancer. So, the most common reason for this is because of the tobacco consumption that we have. So the availability of tobacco, which is in the form of cigarette and BD, is one of the common factors. And of course, that is the smoke form. The smokeless form is the khani and the pan ke saath, the betel nut that we have, which has that chemical in it, the areca. The areca that is carcinogenic, which with chronic exposure, every day eating pan over the years, it adds on every day and it causes a damage in the DNA of the cell. So DNA of the cell is like the home minister. It's like the control system of the cell. So once there is a problem in the control mechanism, that is when one cell divides, multiplies into two, then two becomes four, four becomes eight, eight becomes 16. And that is how actually a tumor develops. So any form of cancer these days, the treatment is usually a combined modality treatment. So combined modality treatment is basically, there are three main modalities. One is surgery, one is radiation, and one is chemotherapy. So surgery is the part where the tumor site and the area around it is removed surgically with the help of an operation. The chemotherapy is the part where there are these highly toxic drugs which are pumped into the veins, which go into the bloodstream, and that is how it kills the cancer cells. And the third part is the radiation, which I'll be focusing more on. So radiation is the part where we are using photons, basically, which is most commonly used. I don't want to be very scientific and into the physics part, but qualitatively, it is something like an X-ray, but a very high dose of X-ray in a very controlled manner. It goes and it is attacked. It is attacked at the site where the tumor is. And in that way, the rays, they go and they attack at the DNA of the cell. So the moment they go and attack the DNA, the cell cannot multiply further. So that is how we achieve cancer cure with the help of radiation. So most of the cancers these days, it is never a single modality. It is usually surgery combined with radiation, or it is chemotherapy combined with surgery with radiation. And the sequence can vary. It can be first surgery followed by radiation, or sometimes surgery followed by chemotherapy with radiation. So in head and neck cancers, the most common site is tongue cancer, that is a oral cavity. So oral cavity is basically comprising of the tongue, the cheeks, the inner part of the cheeks, the area below the tongue, which is the floor of the mouth, and then the upper part. So when you open your mouth, there is a hard palate area. So that is a oral cavity. And then और थोड़ा पीछे जाते हैं तो there is the behind part of the tongue, the base tongue. And then further down, if you come, there is the throat. So in the throat, usually there can be cancer which of the vocal cords. So that is the laryngeal cancers. There can be cancers which is above the larynx, supraglottis, or below the larynx. So these are the most common head and neck cancers. So usually the primary modality in head and neck cancers is always surgery first. And then depending on the report that comes after the surgery, we decide on the need of radiation. And sometimes if it is more advanced, then we add chemotherapy also to it. So there is also something called as organ preservation. जैसे अभी मैंने बोला कि there is a tumor in the vocal cord. So vocal cord is basically the voice box of our body. So voice, I mean, Shrenik ji, you know how important voice is. So voice is like, it is a part of our identity. And who would want to lose their voice? Nobody. So what happens in such type of tumors is we try to do an organ preservation. We try to do a non-invasive procedures where we don't need to remove the voice box. Again, there are situations. So there are some stage where we need to go undergo the surgery. But if it is something very early, something like a T1, T2, a very stage 1, stage 2, or sometimes even very early stage 3 vocal cord tumors also, we can try for organ preservation. So how we do organ preservation? It is with radiation. So what we do in that case is we give a radical radiotherapy dose to the vocal cord area. And depending on any lymph node, if it is involved, we treat that area also. So with that, I would like to elaborate the evolution of radiation that has happened over all these years. So initially, radiation used to be just a very crude form of radiation. It used to be like one beam goes this way, one beam goes this way. So it would be just like, like a box-like field. And whatever area I'm giving the beam, everything is receiving all the radiation. And people would, get this burned skin and everything because it used to be a very, very superficial X-ray type of radiation. So that used to be more toxic and that used to have a lot of side effects. But that is not the case anymore now. So now we have these advanced radiation techniques, which is IMRT, intensity modulated radiotherapy, then IGRT, which is image guided radiotherapy, and then there is something which is VMAT, that is volumetric arc radiotherapy. So what happens is that is we can further give more refined radiation, much more higher dose in a more precise and focal way. So suppose I tell sorry, in the computer software, yeah, I want to target only the right side of the vocal cord or the right side of the neck nodes. I want to give this side more dose and I want to give less dose to this side. So that I can do with VMAT. I can do with all these newer techniques. And at the same time, the side effects are less. So side effects in the sense, post radiation, there is hair loss, there is swelling, there are ulcers in the mouth. So all those things are much, much lower with these newer radiation techniques. Also with these techniques, what happens is during the radiation, all the side effects are lower. And even after completing the radiation, which is the late side effects are also much, much lesser. So late side effects in head and neck radiation are mainly loss of taste, dryness of the mouth, because we have two parotid glands actually here, which secrete the saliva, which is responsible for the saliva production in our mouth. So all those side effects are much, much lesser these days. But having said that, it's not that even with the new techniques, like, there is absolutely no difficulty, no toxicity. There are, but patients don't have to be so scared that, oh my God, मेरा skin पूरा जल जाएगा, मुझसे कुछ खाया नहीं जाएगा, मुंह में बहुत छाले आएंगे, and पूरा black हो जाएगा. ये सब, these are very common phobias that I've come across over all these 15, 16 years of my work with cancer. So yeah, so those things have really significantly changed. Many times patients come and they tell, oh no doctor, मेरे एक relative को radiation मिला, वो तो पूरा skin जल गया, उसके तो झेल ही नहीं पाए वो treatment, वो इतना ज्यादा heavy था कि वो ले ही नहीं पाए, radiation रोक दिया, all those kind of things. So I always tell my patients, you go and you tell 10 other people, tell how advanced radiation has become now, how much more tolerable it is, and how efficacious it has become these days. So that was like a very small, brief, superficial talk of radiation with relevance to head and neck cancers. So I would like to like make it more interactive. Then please ask and please shoot.
Dr. Roy, let me combine with what you said few minutes back about skin turning black like charcoal and kind of problem with your dry mouth everything. See, as a human being and be it professional, be it a businessman or anyone, you know, the important takeaway when you are diagnosed with the cancer, the important takeaway is survival. Important takeaway is survival, irrespective, all the side effects. And as I said, I wanted to align with what you said. I did undergo 35 rounds of radiotherapy. That was, before 27 years. And, there was no technology, modern technology available in those days at JGRI or anyone in India. And so, I believe that, the, the advice which was given by my surgeon and radiotherapy I underwent, that is how I have survived for last 27 years because, there were 56 nodes and so many other issues, but then I have survived. So, it is equally important for all attendees and whoever is going to listen to this uh, session of today by Dr. Roy that, chose intelligently in a smart manner of undergoing the radiotherapy if your advice. And let me tell you, you guys are lucky. You guys are so lucky that there is a lot of advances have occurred in radiotherapy. Dr. Roy, one more question. Can you please tell us, what are the precautions or what are we done while undergoing radiotherapy? Because the word cancer and radiotherapy itself is so scary that people are they forget everything and they are confused what is to be done, what is not to be done. So kindly guide us on that aspect apart from radiotherapy.
Right. So,
Add to that, doctor.
yeah, Josna ji, what? I didn't get you.
No, I said I'd like to add to what Shrenik is saying.
Please do. Yeah.
When the cancer treatment started in India, Dr. Jasawala, who is the founder of ICS, used to refer to it as slash, burn, and poison. That was, I'm talking about 1950s, 60s.
Yeah.
Okay? So it was the infancy of oncology treatment. It was very, very radical.
Yeah.
And it was the doctor, the surgeon, the oncologist's word that was final. Nobody asked the patient what they thought. They just had to lie there and take what was given. Nobody gave them any options. Today, the patient's voice counts a great deal. Yes? Yeah. So, how has it changed? It must have changed medicine hugely because now the focus is on good treatment without scaring the hell out of the patient. So it was not the cancer that killed the patient, it was the fear that did most of the damage.
True.
So if you can elaborate on some of the advances that have made radiotherapy much, much more acceptable.
So one point, of course, that I've told that the techniques of radiation has changed. So earlier, like when you were saying in the 1950s, the infancy of cancer treatment. So during those times, it used to be just like how you go for a normal chest X-ray. It used to be the same X-ray, but a much higher and a very crude form of superficial X-ray, which would just treat, the overlying skin. So in that case, what would happen that we need to kill the tumor. So we need to give a high dose. But because it is superficial, so we need the skin gets more dose, and that the charcoal-like skin, the blackening of the skin. So those things would, happen. But these days, with the refinement of the technique, with the way we can deliver radiation, so I can treat a much more deeper point in the body or in the brain or in the lungs, in the liver, without actually causing much dose on the skin. Isn't that amazing?
Yeah.
So that is the beauty how it has evolved. So that is called as skin sparing radiotherapy. So with more refinement, we have achieved that. We have achieved skin scaring radiation, in which case the radiation is getting focused to a point which is much, much deep within the body. And that too only in relation to the tumor. It is sparing the normal organs. So it is called as organs at risk. Like suppose there is a throat radiation or a tongue radiation I have to give. So my normal organs that I need to save is the parotid gland at the side, the ear which is close by, the rest of the other half of the mouth, the skin of the neck. So all these areas are much more beautifully spared with the new techniques, which is basically IMRT, then further refinement of IMRT, which is IGRT, VMAT, and there is also something very fancy called as stereotactic radiosurgeries. So it is like a surgery, but it is not a physical surgery wherein I'm going inside and cutting with the knife. But it is like a virtual surgery, like without going in, still I'm, ablating the tumor. Of course, the stereotactic radiosurgery is more applicable in brain tumors or maybe in prostate tumors and certain clinical indications. But why I'm mentioning it is, just look at the whole spectrum. कि हम कहाँ थे और कहाँ से कहाँ आए हैं. So that is the beauty of it. Of course, in head and neck radiation, there is not much of stereotactic radiosurgery. It is still more of conventional surgery followed by radiation, or if we are doing a voice preservation and all that, then directly giving a very high dose radical radiation with the new techniques, which is VMAT or a rapid arc. So with that, what happens is suppose my hand, suppose this area I have to treat. So I just focus in this area and I tell my software that, see, I'm treating this area. I don't want to treat this whole area. And the software can focus the radiation beam and it goes and delivers there. So that is how it is different markedly from what it was in 1950s and what it is now in 2025.
I'm just coming back. I have to open the door.
Sure, sure.
Doctor, I have a query.
Yes, yes.
Uh, how do you all calculate the dose of radiation that you give to a patient? Is it by body weight? I mean, do you all calculate all this?
Yes, yes. It's a very good question. And so basically the dose of radiation, there are certain empirical formulations, like in head and neck cancers, like how Shrenik ji has said that he had to undergo 35 fractions. So radiation is always quoted in fractions, unlike chemotherapy, which is quoted in cycles. So radiation is given one fraction over 1 day, and most common fractionation is 5 days in a week. So it's usually Monday, Tuesday, Wednesday, Thursday, Friday, and Saturday, Sundays are usual off, unless there is some palliative case and patient is in a lot of pain. So that is a different scenario. So usually what happens is after surgery in head and neck cancers, the usual dose is 6 weeks of radiation and the usual dose is 60 gray. But this is not generalized. I cannot say the same is applicable in breast cancers or the same is applicable in brain tumors. So depending on the type of the tumor, what is the histopathology basically? What is the type of cell? and which site of the body the tumor is in, the radiation dose is decided. Also, this is not enough. We also need to know what is my intent of treatment. So intent is whether I want to achieve a cure or whether I just want to palliate the symptoms. So a palliative radiation is much, much less lower dose because that is usually for pain control and all those things. But a radical dose is where I want to like totally cure the disease. So I give a much, much higher dose. So that is the gross bifurcation. Of course, there are fine tuning to everything, but this is the gross way that we decide the dose.
And they say that Madame Curie herself died of cancer. So, what is the potential side effects of radiotherapy?
Yeah, so unfortunately, Madame Curie was so passionate about radiation and studying radioactivity. And in those days, nobody knew that, with constant low dose radiation exposure, what is happening to the body. So she had worked so much with radiation, and she used to like literally hang around in the lab, and her family would also be there in the lab. So she had developed a sort of blood cancer because of the low dose radiation exposure. So one of the late side effects of radiation is developing blood cancer. One of it is, but it's not necessary that every patient who undergoes radiation will develop a blood cancer. And also it depends on the total cumulative exposure. So in case of Madame Curie, because she was constantly working with it, I'm sure the dose was much, much excessive, which caused it. But the same is not true in the cancer patients because here we are giving more controlled exposure.
What does it do to the radiologists today?
Sorry, Josna ji,
No,
what did,
yes, please have your water.
yeah, thank you so much. Yeah, you were telling?
I said that Priya brought up the issue of Madame Curie. I'm asking you, what does all this radiation do to the radiologists themselves, the radiologists and the radiographers?
So yeah, so what we do is, because for us it is an occupational health hazard, constant radiation exposure. But luckily these days with the newer machines which are basically linear accelerators, there is no constant radioactivity in the machine. So the radiation beam is switched on only when the patient is on the couch, only when I'm, turning the button on and the radiation beam is getting delivered because it is getting produced on that time. But earlier days, the 1950s and 60s, what used to happen is there were proper radioactive source in the machine. So there used to be a cobalt source in the radiation head of the machine. So with that, there used to be constant low dose exposure, constant leaking going on. So there are some devices which radiographers wear, the radiation oncologists.
A lead apron.
No, so unfortunately for this kind of radiation, lead apron don't help because it is higher dose of radiation than a normal X-ray. But there is something called as TLD. It is a thermoluminescence dosimeter. So it is like a small batch which, most of us, yeah. So it monitors in case, there is any accidental exposure, it goes for 3 monthly checks.
Right.
So the radiation safety officer actually is in charge, and she keeps a a check who's getting how much of occupational exposure. And there are strict limitations guidelines by the Atomic Energy ARB of India who keep checking that data. So if there is any breach, if there is any excess, then they come and they do the needful then. So we are all well protected.
Good. No, we have a screening system in ICS.
Okay.
Ours is very low dose X-rays and mammography. but our personnel wear the lead apron as well as the TLD badge, and it is monitored constantly.
Wow. Yeah. Yeah. So that's the way.
Ma'am, I would like to add one more thing in the radiation questions. So, what are the other radiations in day-to-day life that we get exposed to, and we should take care of them?
So this is therapeutic radiation. What I'm using to kill the cancers in
Yeah,
people.
yeah.
Yeah. So then, there's a nice chart in radiation physics which tells, the type of radiations. So one is natural, one is man-made. So of course,
Mm.
natural radiation, you get exposed to cosmic rays, you get exposed to, people who have very frequent flights, who travel a lot by air. They
Okay.
relatively get more of these cosmic radiations and all that. Other than that, other than my branch, that is the radiation
Mhm.
oncology, there is a branch called as nuclear medicine.
Yes.
Yeah. So in nuclear medicine, they deal with radionuclides. So they are actual solutions, which are radioactive, and it is injected in the
Mhm.
body. So that is a different kind of radioactivity
Okay.
exposure. Yeah. And other than that, there is a sort of radiation which is in the Earth's atmosphere also. But all that is much, much below the threshold as such. Unless your work involves lot of traveling or going to space. So these astronauts and all,
Mhm.
working in space stations. So their levels are there, the level that they receive is much, much higher than what normal people who are like suppose like normal people.
Yeah, true.
So that's the thing.
So we don't need to worry about the little radiations and all. They are fine.
No, that's fine. That's fine.
Okay, thank you.
But yeah, I mean, it's an interesting question because many patients come and then they say, especially people who have never smoked, people who
Yes.
drink. So they come and tell कि डॉक्टर मैंने तो कभी शराब भी नहीं पिया, कभी सिगरेट भी नहीं पिया, तो मुझे कैंसर कैसे हो गया? You know,
Hmm.
especially these oral cancers, throat cancers, lung cancers. So then how do you justify that? Because even though we know many things, but still I would say, and most people will agree with me, that there is still so much that we still don't know.
Yeah.
So sometimes there is a random hit, there is a random mutation. Maybe it is due to some sort of radiation exposure, some sort of air pollution, water pollution, insecticides, pesticides in our food, which
Yes.
goes and causes the deranged machinery of our cell and gives rise to cancers.
True.
Dr. Roy, I'm typical example of what you explained just now. I mean, I have never smoked, never consumed tobacco, non-alcoholic, speak vegetarian, but eat a gun. But I rather consider this as a blessing in disguise because this has given me altogether a new identity, passion to lead quality life, and that was after stage 4 vocal cord cancer. Dr. Roy, please enlighten us about making the mask. I mean, is it still masks are designed for giving radiotherapy? Number one, and what is the role of a physicist who is designing the mask and giving the specific targeted radiotherapy?
So, Shrenik ji, it's like really nice and it's very inspiring that, like you said, that you didn't have any of these risk factors and you still landed up with this cancer. But that is commendable because you could embrace it and you could accept it, and take it ahead in a very positive way. But again, not everybody is blessed with so much of mental strength. And yeah, I mean, it takes a lot of motivation to overcome the negativity and then turn it into something positive and then work on it like that. So, hats off to you for that. The other thing is, you asked me about the mask for the radiation. Yeah. So the immobilization thing that is usually okay. So basically for head and neck radiation, the mask is very important because what we don't want is somebody who's getting treated for a tongue cancer or a throat cancer, like in your case. I don't want the radiation beam, to go in some other area because I want to treat only my target. Also, I don't want the patient to move during the radiation beam on. So that is the fundamental reason, why we make a mask. And the mask is usually made of a type of plastic, which is called as thermoplastic. So thermoplastic is basically the property is that when I put it in a hot water, which is roughly around 65 to 70 degrees Celsius, it becomes soft. It becomes soft, it becomes pliable. And then the mask is usually placed on the head and the neck and the shoulder area of the patient. So it takes the shape. So it is more like a customized immobilization device. So the patient doesn't move. And at the same time, there are some openings for the eye, for the nose, and for the mouth. So you don't feel claustrophobic inside. Though some patients still feel a lot of, suffocation, but still, I mean, still at least it's much better than a total closed net-like thing. So it is the first step of the radiation planning because without that, we cannot take any patient for head and neck radiation. And then wearing the mask, a mapping scan is done. So that mapping scan is usually my reference image. On that scan, we draw the normal organs that I don't want to radiate. And then we draw the target organs or the target area where I want the radiation to go. So Jyotsnath ji, this is very different from the 1950s radiation. Where,
Yes.
so where usually there used to not be much of a mask and drawing and all those things. So we do a lot of drawing, painting, color wash, this, that. It's very colorful, very colorful.
Yeah. No, I realize it's come a long way, but I think a lot of people, I wanted you to talk about the early days and the
Yes,
the
yes,
radical treatment as compared with what is happening today.
of course, yes.
The fact that today the patient's voice is heard.
Yeah, yeah, because it's always a shared decision making. So it's not key what I want the patient has to do, because many times the patient may not want to undergo a certain type of treatment, even though it is a advice treatment, because it's after all my body, it's the patient's body, it's the patient's choice. So we have to respect that.
It always was, accepting that it wasn't respected. That's the point I was making.
Exactly, exactly. So yeah, it's always an informed decision making. It's always a shared decision making.
Mm.
Sometimes some patients have a lot of phobia. I don't want to undergo chemotherapy. Whatever the chances of the tumor coming back, I'm okay with it. That kind. Yeah, I'm okay if there is a 50% chance of tumor coming back. I don't want to take chemotherapy. I'm scared of losing my hair. I'm scared of the nauseas and the vomiting and everything. And it's perfectly fine. I mean, the patient knows that the patient can get a recurrence and still is accepting of the fact and denying the treatment. That is fine. Or opting for the treatment. So
Mm.
that is the way it has evolved. And I think it's beautiful. I mean, it should be always this way, but as you said earlier, the choice was not given or whatever, I don't know.
Even today, I feel that in many small cities and small hospitals, the patient's choice is not respected.
uh,
How do we reach them? How do we?
so we reach them by making such talks, and so people
Yes.
listen on social media, people listen on YouTube, and I think it does make a lot of difference. It is gradually changing the whole scene, and it will be even more different and better, I hope, in the next 5 years, 10 years. Because it is not possible to go door to door for individually, for
Yeah.
one person to go to 10,000 doors. But this is a good way of disseminating it. Like you and I discussing, 10 people listening, those 10 people going and telling another 10 people, and then 10 to 10, so that kind of geometric progression. So I think there is magic in it. That way we can. Correct me, Amina,
Malik,
correct
I'm
me if I'm
really
wrong.
wanted to
Absolutely.
ask. Uh,
Can I ask a question, Dr.
Yes,
Roy?
yes, sure, sure. Yeah. Go ahead.
I just want to know how do you help the patients with the side effects of the treatment?
Okay.
During the treatment, because it's very intense, very painful.
Yeah.
So how do you, because like you said, they're so scared of it.
Yeah.
So they can't eat, they can't talk, they get ulcers. It's very painful. So how do you help them during that time?
Yeah. So usually,
We help them also.
pardon?
And how can we as That's the reason why I'm asking,
Yes,
because
but that's what it's not what she will say, but what we have to do. Tell us what to do.
yes.
Right. So, of course, apart from the weekly monitoring, so what happens in head and neck cancers is because there is some sort of loss of taste, there is a difficulty in swallowing, usually around the third week. There is soreness in the mouth, there is dryness in the mouth. So the intake goes down. So what we tell, the first thing is keep yourself, your nourishment really up the mark. So small, frequent meals, making it more calorie dense. So even if the patient is taking maybe half a plate of khichdi, but we make it more calorie dense. We put more ghee in it, butter in it, adequate amount of salt. Even though the patient may lose the taste, but the caregiver or the family who's taking care sees to it that these things are maintained, because nutrition has a very direct effect in the overall treatment tolerance and the outcome also. Because
Mm.
if the nutrition goes down, then there is a treatment break. Now the treatment break will again affect the overall outcome, because my survival will get compromised if there are treatment breaks or if there are too frequent treatment breaks. So that is one thing. Secondly, of course, if whenever there are oral ulcers, mucositis, skin breakdown, then there are local anesthetic gels that are given. So that causes, soothing of the oral mucosa and all those linings and all that.
Toothpaste as well.
Toothpaste as well. Then there are some liquid syrups which soothe the throat area. So before taking meals, we advise the patient take 2 tablespoons of this, mucin gel and all sort of liquids like that, which soothes it. Maybe it causes a little bit of local anesthesia. So that helps in eating. So these are, of course, the medical parameters. But apart from the medical parameters and the nutrition, it is the mind also. So it is how driven and how optimistic the patient is. So sometimes the patient is in a very negative thought mode, a very negative, pessimistic, mode. And I mean, you can't blame it. I mean, it is not a pleasant journey after all.
Yes.
So in spite of having all the obstacles, looking forward to a positive, optimistic outcome is, I think, really helpful for the patient as well as the family, to go through the whole journey. So, as many a times I feel, talking to a psychologist helps in that cases. Also, sometimes I feel there is some sort of mild depression many of the patients have during that phase, So, combat identifying those signs and then, taking actions against those, how to cope it up, that really takes a long way ahead.
Do you have a support group in your hospital?
So yeah, I mean, I have an online support group which I organize. I try to do it like once in a month or once in 2 months. I think it's very helpful. In our hospital also, we had one ongoing before the COVID. It was like very regular, but I'm trying to like revive it because it really helps. Patients coming and sharing their own story. And whenever like two people are going through the same journey, it is always, more relatable.
Yeah.
So it gives strength. It's like mutually, encouraging each other. So
Uh, Dr. Roy, I have two more questions.
yeah.
Uh, Overall, on an average, I mean, not for educated, but people in general, when someone is undergone radiotherapy, people are scared, particularly relatives, like, stay away, radiotherapy लगा लिया हुआ है, हमको इन्फेक्शन लग जाएगा, ये हो जाएगा, वो हो जाएगा. I want you to address that point. And number two, I mean, there is a lot of, information shared on various platforms, particularly on web browsers. Okay, cancer away, don't eat sugar, don't do this, don't do that. Particularly, I want to go address that sugar aspect as well. कि बोलते हैं शुगर खाएंगे तो कैंसर बढ़ जाएगा, रिकरेंट कैंसर होगा. I wanted to address these two questions, please.
Yes, so of course, both are very much relevant, Shrenik ji, and they are very important questions that you have asked. So, whenever a patient is undergoing radiation, the patient is not becoming radioactive. So, you've undergone it. So, there was no radioactive dye or any metal or any radioactive source in you. So, when you are taking radiation, when the patient is taking radiation and going home, there is no radiation exposure which is, given out to the others. So, cancer patients who are undergoing radiation are absolutely safe around small children, big children, old people, pregnant ladies. There is no radiation exposure from the patients. The second question that you said about the myths and the fad, the food fad these days, partly also it is because, we have all the information just at the click of a button. So everything you do, you put it on Google and you will get like hundreds of information, which is good, but also dangerous. So I always tell my patients, almost every day there is one patient I at least tell that, see, if you're reading online, you read the source कि आप कहाँ से पढ़ रहे हो, क्या पढ़ रहे हो. ऐसे नहीं कि मेरे नेबर ने कुछ बोल दिया है और वो ही सही है. नहीं, आपको देखना है कि जो बोल रहा है वो एक्सपर्ट है क्या उस सब्जेक्ट का, है ना. If I'm reading something about maybe breast cancer or tongue cancer, I will read national guidelines. I will read ya to Indian guidelines, ICMR guidelines, or I will read American guidelines like NCCN, National Comprehensive Cancer Network guideline, or I will read British guidelines. So these are very, very fine, crisp guidelines given. And the beauty is in the guidelines also, there is one simplified patient information, which is more easily digestible for patients because it has less of medical terms, less of jargon in it. And there is one which is specialized for healthcare workers, doctors, nurses, physiotherapists, everything like that. So I always tell you, see the source. So this sugar wala thing is very interesting because there is a lot of Chinese data which had, people have got me books कि देखो डॉक्टर ये बुक में 10,000 patients का है डेटा कि चीनी खाने से कैंसर होता है, इसलिए जिस दिन से हमारा बायोप्सी रिपोर्ट पॉजिटिव आया है हमने चीनी खाना बंद कर दिया है, हमने दूध पीना बंद कर दिया है, दही खाना बंद कर दिया है, चीज खाना बंद कर दिया है, क्योंकि ये सब से कैंसर फैलता है. There is no scientific evidence to it. There is no scientific evidence. See, everything in moderation is good. अभी चीनी खाने हाँ किया तो that doesn't mean you eat 5 kilos of चीनी ना every day. है ना, you can't do that. But yeah, I mean, you have 2 cups of tea if you have 1 teaspoon of sugar in the tea, and you're not eating rest of the junk food and not smoking, not drinking, exercising adequately. There's nothing wrong in it. It's perfectly fine. But these days, there is so much of, again, technology ka disadvantage ye hai कि there is so much information available. There is an infodemic कि ये खाने से वो हो रहा है, वो खाने से ये हो रहा है. No, everything has to be checked. कहाँ का information है ये? So that's the only way I think.
Yeah, Dr. Roy, I want to share my own experience throughout my journey of 10,000 days since I was diagnosed and underwent treatment, etc. Believe me, I have never browsed anything at all about cancer. No, zero. I mean, if something goes wrong, I go to the expert and ask him that I want you to sort it out, how you do it, what you do it. That is purely God because I am not expert. So, this should be the ideal approach because, unnecessarily say if you are not medically qualified and then, if you browse, then, it leads to a lot of misinformation, confusion, and lot of things. So, ideally, I strongly recommend that, don't fall for those information if you are not medically qualified.
Hmm. Hmm. Yeah, yeah. So that's what I mean. You realized that, right? I mean, you didn't just keep reading ऐसे कि हाँ ये भी पढ़ लिया वो भी पढ़ लिया अच्छा इसमें ऐसे होता है ऐसे मेरे नेबर ने बोला नेबर के फ्रेंड ने बोला ऐसे मेरे रिलेटिव ने बोला you can't use that like how in court you have to give the IPC number कि उसके बेसिस पे ये ऐसा ऐसा है यू कैन जस्ट कोट सम रैंडम थिंग कि मैंने ऐसे पढ़ा है चाइना में ऐसे बोला है some study no everything has to be with a proper evidence and there has to be scientific guidelines for it and then you follow it.
Absolutely. And that is the reason, we are inviting specialists like you to our session at Indian Cancer Society so that, we can spread more and more awareness and, taking care of, myths and, we want people not to follow unauthorized information so that, that is the only purpose we are doing it. Jyotaji, and Ritika, is there any questions? Because we are close to 7 now. So,
Not from
uh,
Shrenik bhai. I think I've talked enough. Thank you.
Yeah, I mean how time flew, right? It's almost 7, it's going to be 7 now.
Doctor, I'd like to ask one query.
Please go ahead.
Radiology and its use in prevention, in treatment, and end of life stage.
No, you mean radiation, right? Not
Yeah,
radiology.
sorry, radiation in these three aspects.
So radiation in what
Can
was
we do prevention also? Can we use radiology in
radiation?
prevention
No, radiation for prevention. See,
to
preventing
make the
cancer.
environment so sterile?
No, preventing cancer by radiation is not possible. But yes, preventing unnecessary radiation exposure, like um, preventing unnecessary radiation exposure, that of course is can prevent cancer. Like sometimes some patients they undergo too many scans. There is no data which will tell you that if you have 100 CT scans, you'll get cancer. ऐसा कोई डेटा नहीं है बट यस द मोर द एक्सपोजर्स देयर इज अ स्मॉलर चांस कि बाद में जाके 10 years 15 years 20 years down the line there can be some sort of cancer, especially these type of blood cancers. They are quite notorious for long term side effects of chronic radiation exposure.
But
So that,
doctor, I'm sorry I said I wouldn't speak, but I have to ask this question.
yeah.
We have a lot of patients who come to us who tell us that before every appointment,
Yeah.
particularly in childhood cancers, they are told go and have an MRI and then come for your appointment. Go
Okay.
and have a CT scan and then come for your appointment.
Yeah. Yeah.
Is that not excessive and unnecessary?
So Jyotsna ji, what happens is, it's like you said in pediatric cancers or any cancer, we need the information. We need the imaging information to understand where the cancer tumor is, where has it gone, what is the nature of spread, and whether any normal surrounding areas also affected by it. So having one CT scan, two CT scan does not cause cumulatively cancer. It is an important information which is needed for staging the cancer also. So that is all justified. Second thing I would like to clarify is that MRI is a type of imaging which does not have radiation exposure because it uses the protons in the body itself to generate the image. So in fact, when pregnant women have to undergo some imaging, usually they are advised ultrasound or MRI. not CT scan. Yeah.
Yeah.
Because these are very safe sort of imaging without radiation exposure.
Thank you. That's important.
Welcome.
Dr. Roy, that is one question on YouTube by Dr. Nalini. Uh, she's asking how long does radiation remain in the environment? Explain in a chronological order. Do you want me to repeat? How long does radiation remain in the environment? Explain in a chronological order.
So one one thing I would like to clarify is, see, radiation also, there are types of radiation. There is electron radiation, proton, photon, cosmic radiation, terrestrial, extraterrestrial. And it is not that radiation अगर है atmosphere में तो it is there for some time and then it just disappears. It's not that way. So the natural radiation जो है, जो earth के atmosphere में है, that is due to the space and all those rays and all. So that obviously will not go away because we are living on earth and there is a way the planets are going on like that. The other thing is, during the cancer treatment जो machine से emit होता है radiation, so radiation is not there in the air in that case. The radiation is focused and delivered to the area of interest in the body. So it is like, if this is my machine and this is the body of the patient or the tumor, the radiation is going and hitting here. In between, the air is not getting radiation. It's not that way. But that is a path of the radiation beam. But the dose deposition is in the tumor only. So it is not that, कि मैंने अभी beam on किया तो after I switch off the beam, there is still radiation lingering in the room. ऐसा नहीं है. That's not the case. So I hope that clarifies the doubt.
I think so.
I love these questions. I mean, it shows that how much of how many things actually are not known to normal laymen. I mean, there is still so much to tell, so much to learn.
Yeah, and then here again, I mean, people get to know something which has never occurred in their mind, and
Correct.
that's how they can get this such kind of knowledge from expert like you. Ritika, is there any question, or else we'll start wrapping up?
Ritika is herself not well, Shrenik bhai. So maybe
Okay, okay.
you should just
Yeah,
stop.
yeah, yeah, I think so. Because Vaishali just sent me text, so I think so. So fine. Let's start wrapping up. Dr. Roy, thank you so very much. We are deeply grateful for everything you talked about. I mean, it was completely interactive session as we have talked at the start of the meeting. So
Thank you.
thank you very much, and we would love to have you once again in the near future. And we wish you commendable time and great 2025. And yes, a lot of energy, lot of enthusiasm, to treat more and more people at just from hospital. Thank you, Jotaji, thank you, Priya, and everybody present today. Thank you.
Thank you, Shrenik ji. Thank you, Jyotsna ji. Thank you, Priya ji. Thank you, all of you, for the lovely questions. And I always enjoy these sessions. I mean,
Great.
okay.
Thank you. Bye bye. Bye.
Bye. Bye. Good night. Bye.